Yeah, so guys, there's no Zoom lectures, nothing the next 2 days, just, okay, because we can't give Zoom lectures. What if some people don't have power, some do, so we can't give Zoom lectures. But the thing is, you're still going to have all the classes. Just pay attention to Outlook, because any of those free spots that were there may not be free, depending on what courses need to be added in there, okay? The important thing, guys, is just be safe. If you're not from Florida, don't worry. It'll be okay. Just stay inside and just relax. Have drinks on hand, whatever drinks you want, because you can't go anywhere. Water's good. Okay, yes? You have a question? We got it figured out. Just watch Outlook. I haven't had a chance to do Outlook yet, but Outlook, I know for a fact next Tuesday afternoon you're gonna have Ankh there. So next Monday and Tuesday are both afternoons are Ankh. So the Ankh tomorrow got moved to Tuesday afternoon. The other classes will be moved eventually. I was doing interviews this morning. I haven't had time to float around the schedule. So dementia. Moving on to all you have left today is dementia and stroke. That's it. So dementia is an acquired decline in intellectual function. So it's intellect. The end result is loss of social independence. They can't take care of themselves anymore. What do we call those things? I think someone said it. ADLs, your activities of daily living. Your job is to figure out, can this person go home on their own? Can they take care of themselves if I discharge them home? Dementia, over time, they will not be able to take care of themselves. They're going to require care. Some of you worked in memory care in an assisted living facility. You'll know exactly what I'm talking about. What are some underlying causes? Dementia, number one, is underlying Alzheimer's disease. Alzheimer's is a form of dementia. It is not the only dementia. So Alzheimer's dementia is a form of it. The other type is vascular dementia. What kind of underlying disease do you think would cause vascular dementia? Not a stroke. Hypertension. Hypertension is a very, very big one that causes these types of vascular infarcts. And then you'll see, as you keep going, then you have your mixed, which is between vascular and Alzheimer's. Then here's your 4% Lewy body. Okay, Lewy body dementia, they have those inclusions. We talked about with what other disease gets Lewy bodies? Parkinson's. So make sure when you're studying about Parkinson's, make sure you understand what ubiquitin, alpha-synuclein do, and Parkin. All three of those genes have a role in the development of those Lewy bodies. It is not a normal consequence of aging. So being forgetful is one thing, but there's a difference between forgetfulness and dementia. Dementia is not a normal consequence of aging, but there is an increased incidence with age. It goes up. Characteristics, memory impairment. For the most part, the family members are going to be the one to tell you what's going on, not the patient, because they don't realize that they're forgetting things. It's the family members that are going to say this is what's going on. They may have some other issues going on. These are all higher context thoughts. When you guys start behavioral health in the winter, and you guys did this already a little bit with your mini mental status exam and physical diagnosis. What are some questions that you guys asked in your physical diagnosis for a mini mental status exam? Last three presidents, that's your long-term memory. What else are you doing? 3 words. Remember them in 10 minutes. That's your short-term memory. Some patients with dementia, their short-term memory is not there, but the long-term will still be there. It depends. Spatial orientation. Not so much where are you, but you haven't done it yet, but you have to draw the intersecting, well, I drew squares, but you have to draw pentagons and intersecting pentagons on your paper. You'll get to that when you do the full There's a lot more to that status exam you guys haven't done yet. You've only done the first part. There's more to it, more questions you're going to be asking to figure out what their thoughts are. You have them write a sentence down. You give them a statement. You say, there's a statement on this paper. Follow the directions. And it's made to say, fold the paper in half and put it on your right side. Can they follow directions? So these are all things that you'll be doing on your mini mental status exam. Symptoms over months to years. This is a long-term disease, long progression. So one of the things, and I'll mention it over here. Etiology, again, we've already talked about. Alzheimer's is the biggest one. Infarcts, which is your, this is your lacunar infarct or the vascular. The vascular infarcts, they behave differently compared to the normal progression of dementia. With normal dementia, the progression is like that. Progressively declining over time as you go. With vascular dementia, they'll be fine for a while and then they have a major step off. Decline in function, immediately decline in function. And then they're okay for a while and then they have another drop off in function. And then they're okay for a while and it's this stepwise progression. What do you think is happening every single time you have a steep drop off? They're having another infarct, another vascular infarct. And every time they have a vascular infarct, depending on what part of the brain is being that's responsible for whatever it is, that's where you're going to have your deficits. So the whole part of the brain has already been mapped out. We know what parts of the brain do what. That's why when you're, yes?
Sorry, what's that word next to it?
Oh, let me erase it. It's lacunar.
That's the name for that.
Yeah, they're called lacunar infarcts or vascular infarcts. It's the same thing. Okay. So this is like a big mind map. Don't worry about it, going crazy studying this. It just goes over like the common types of dementia. Here's your Alzheimer's, and it kind of goes into detail. You can go like, what are the symptoms that they have with this type of dementia, and so on and so forth. Just going over different types, but we already gone over that. So let's focus on Alzheimer's. It's the most common cause of dementia. Slowly progressive, 5 to 10 years, takes a long time. 10% are familial, so there is some genetic component to Alzheimer's disease. Typically it begins with impairment of learning, recent memory. So again, that short-term memory is going to be affected the most. The long-term has been in there for a while, established connections, but the short-term one won't connect. So anomia, can't recall the name of everyday objects. What thing do you do in PD to figure that out? Close their eyes and put an object into their hand. That's why I tell you, who I've had for skills exams, don't use a reflex hammer and a tuning fork, because they don't know what that is. Use a pen, chapstick roll, a coin, something that everyday people are familiar with. Aphasia, loss of ability to understand or express speech. That is why, what type of questions should you always want to be asking your patients? Open-ended or closed-ended? Open. You want to see how they respond. How do they answer? If I just give you closed-ended questions, are you hot? No. Does that tell me anything about the way they speak? Do they comprehend things? All they're answering is yes or no. You don't know if it's being truthful or not. Open-ended questions, get them talking, see what's going on. Acalcula, can't do simple math. And then obviously loss of in employment, so obviously your ADLs get affected. This is a patient who was an artist, and this is what happened over years of Alzheimer's disease. How they did their self-portrait, deteriorated over time due to Alzheimer's. So, spatial disorientation, getting lost frequently. You always hear those stories of those old people get out of their house and they're wandering around their neighborhood lost. Okay, spatial disorientation, they don't know where they are. That's why if you ever go to these memory care centers, They look like malls or like little avenues or little storefronts so that people are used to seeing these things and they know where they are. I saw this great thing where they should turn all like abandoned malls into like nursing homes and like facilities. You got everything there, food court, movies, turn all those stores into apartments. Good to go.
Like a neighborhood.
Oh, really?
Doors were like houses of doors, and then they like painted like the house on the walls.
Yep. Apraxias, this is your ADLs. They can't cook or clean for themselves. Gait disturbance, similar to Parkinson's. What kind of gait does Parkinson's patients have? Shuffling gait, turn on block. They can't just do their like, coordinated movements. Social graces are lost. So things that they normally wouldn't say normally, they start saying now because, again, what lobe is responsible for discretion and stopping you from doing stupid things? The frontal lobe. And they get frontal lobe atrophy. So that guard that's preventing them from doing things is not there anymore, so their social graces are lost. Psych issues may appear in later stages, paranoia, hallucinations. So this is what's going on. We get these neuritic amyloid plaques that they're found in the cortex, in the wall of meningeal, and in the vessels. They cause these intraneural neurofibrillary tangles. And this is a tangle right there. You see how all these filaments here look normal, those tracks are nice and clean. Then you look at those neurofibrillary tangles that go on with Alzheimer's disease. Do you think any conduction is going on in that nerve fiber? No, not anymore. So you lose those functions of these nerves. So you get these neurofibrillary tangles. You also get amyloid plaques for the same reason that you get them in Parkinson's disease. The synuclein, ubiquitin, and Parkin genes are all faulty and they cause amyloid plaques. So the two major things that you'll see with Alzheimer's disease, those beta amyloid plaques and those neurofibrillary tangles. Those two things are always going to see with Alzheimer's. Unfortunately, again, you really can't see it until the patient has passed when you do an autopsy. But there are more sensitive technologies coming out that are trying to pick these things up earlier. I think there's even dogs that can smell Alzheimer's now. So when we talked about scent, because of evolutionary changes, we don't rely on our sense of smell anymore, so we've lost a lot of our receptors. But the dogs have like thousands and thousands and thousands of smell receptors compared to what we have, so therefore they can pick up a lot more than we do. So neuronal synaptic loss, there's no more transmission of the signal to other neurons, therefore nothing's going to happen in those areas. Reactive astrocytosis, here's our microglial proliferation. Remember, what is the microglial? What's the type of cell they are? What's their function? Immune system, their immunity. And we also get some changes in the hippocampus, entorhinal, association cortex, basal forebrain. Again, social graces.
Do you see this on an MRI?
Not a normal one. They get special ones, like those PET functional MRIs, but I don't know exactly what they do to see all this stuff. One of the things that, and with PA school, especially when you start getting to like reading for the pants and everything, we have to teach you what the gold standards are. Gold standard means this is what the whole, either the country or the world is saying for determining this diagnosis, this is the treatment to do all the time, or this is the diagnostic study to do. That's what we have to teach you. We can't teach you like the new stuff because they're not going to test you on it anyway because the exams aren't written. They're years ago. And then the newer technologies aren't officially gold standards yet. Once they do become gold standards, then we're going to start talking about it. So again, main protein is that beta amyloid plaque, derived from this beta amyloid precursor protein. And the purpose of this APP, amyloid precursor protein, is support the growth of neurites. Okay, so anything coming off of that cell body, that's the role. However, it's suggested that some people have an extra copy of this APP gene, therefore they're producing too much because they have an extra copy of that gene, and likely is going to be causing that neural degeneration that occurs. So in that familial cases, the genetic portion, obviously the APP gene is going to be affected here, or they're going to show up here. And obviously anything that's going to alter synaptic transmission is going to alter the conduction of that electrical signal, and it's going to go away. So again, this is on autopsy post-mortem. The reddish brown are the amyloid plaques, and then you can see these tangles, those little brown, black little spots everywhere. Those are those neurofibrillary tangles. But again, only seen on autopsy. So we have found through many, many years of testing that there are certain apolipoproteins that may predispose you to having Alzheimer's disease. We talked before about these apolipoproteins. What are these apolipoproteins? Like we have, what are some of them we learned about? We learned about ApoB, remember? Okay, maybe not. Apolipoproteins are the little hats that are on all the cholesterol molecules. And they tell the liver, is this a good cholesterol or a bad cholesterol? ApoB is on LDLs, and it causes that. There's these isoforms called apolipoprotein E, and they have E2, E3, and E4. But E is the one that we're talking about today. The whole purpose of apolipoprotein E transports lipids and supports injury repair in the brain. So APO4 isoform increases the risk of Alzheimer's disease. You can test this. It's a genetic test. You can do it very easily. But one of the reasons why you gotta be careful is because if you ever want to go for like life insurance policies, they want to see all your labs and your last notes. And if you got this done and they see it, they're going to reduce you for insurance. I had a patient just the other day, he was applying for health insurance, and one of the things that will tell you with EKG, never read the interpretation that the EKG says. EKG will spit out, oh, this is what my interpretation is. Don't read it half the time. On this person's EKG, it said borderline ECG because they had a right axis deviation, which is fine. He's he's an athlete, so he's like 6'9", so obviously very, very tall. Heart shifts in a spot. They reduced his life insurance because of that one word there, because borderline ECG was in there. So these insurance companies are ruthless. Anyway, ApoE4, if you have this wild type of apolipoprotein, increased risk of Alzheimer's and so forth. There was an actor who came out a few years ago and said that he had this wild form of ApoE4, which predisposes him to Alzheimer's. We took a break from acting for a little bit, and we know who that was. Chris Hemsworth, yep. Okay, so he has this wild type, therefore he has a risk for Alzheimer's. Doesn't mean he's going to get it, but the risk is there. So you can see here, this is your normal side. And on the right is the Alzheimer's brain. Look at all that cortical atrophy going on. Okay, widened sulci. If you have a widened sulci, that means you are undergoing atrophy because a sulci is the dips. And if they're getting wider, that means you're losing tissue, undergoing cortical atrophy. So widened sulci, which you can see up here, top right up there. So widened sulci. All due to atrophy, all due to Alzheimer's disease. Moving on to strokes. Strokes and heart attacks are very similar. So when you're learning about strokes, you're learning about heart attacks, similar. Why are they similar? If you have a heart attack, you're going to start learning about 12-lead EKG soon. You're going to localize what vessel was the culprit. What vessel caused you to have that heart attack? Same things in the brain. We have the brain mapped out. We know if you're coming in with right arm numbness and tingling, you can't move it. We know exactly what part of the brain is responsible for that. We know what vessels feed that area. So again, as we're starting to know again, stroke, sudden onset of focal neural deficit at least 24 hours due to abnormal cerebral circulation. Why is it important that we say 24 hours? If it's less than 24 hours and you get full resolution of all your symptoms and you're back to normal, we call that something else. A TIA, a transient, that's short-lived, ischemic attack. TIA It's transient, short-lived, resolves on their own. The problem with the TIA is that it usually means there's a big stroke coming. So that's when you start going into your secondary prevention. Okay, we talk about primary prevention and secondary prevention. This patient already had a TIA, so now what kind of prevention are we talking about? Secondary. We don't want them to have the second stroke. So now we're under secondary prevention. Primary prevention would have been preventing the first one. Third leading cause of death in the United States, more men than women. Obviously, by now, all of these risk factors should make very good sense. Why these risk factors lead towards stroke. Okay, here's a good one. Okay, so when we talk about strokes, we have to talk about the type of stroke that happened. All MIs are the same, blocked artery. Okay, but with strokes, there's two different types. One is very, very lethal. The other one is lethal, but not as bad. There's two major stroke types. The end result is ischemia. But how are we getting that ischemia to the tissue of the brain? Did we have an ischemic stroke, vascular occlusion, same thing as a myocardial infarction? Clot got into that area, or you had vascular damage, shear forces, all these things keep coming back. Platelet accumulation in the cerebral vessels, and now you have a stroke. That's called an ischemic stroke due to a blockage in the artery. The second one, hemorrhagic stroke. Now you have burst vessels. That vessel ruptured in the brain, and now blood is leaking out into the brain parenchyma. So they're both causing ischemia downstream, but what is the underlying cause? The hemorrhage has a location of the bleed, but also the important thing is this: increased intracranial pressure. The skull is fixed, can't expand. So as that more and more fluid starts oozing into that brain system, the skull is keeping it tight. So what's going to happen is you start compressing brain structures. Severe headaches, brain edema, compression of neighboring tissue, can cause seizure activity because now you're compressing tissues. They get irritated, sending off signals, causing a stroke to happen. Which is why any patient coming in with a new onset stroke, you have to scan the brain to make sure there's no tumor there. Because if they have an underlying tumor or a mass compressing tissue, it can cause you to have a stroke. Always check the CT, see what's going on. They can rupture and bleed into the ventricles or that subarachnoid space. So hemorrhagic strokes, these are your epidural hematomas, subarachnoid hemorrhages. Those are forms of hemorrhagic strokes because there's bleeding going on. So pathophysiology for an ischemic stroke, again, you can have thrombotic occlusion. These are your larger vessels. Could be a small vessel. This is your lacunar strokes, or venous occlusion, or an embolic stroke. Okay, who is at high risk for embolic strokes? Atrial fibrillation patients, right? They have where is the clot forming in atrial fibrillation? What chamber? Left atrium. Okay, follow your anatomy. It breaks free. Left ventricle, aorta, carotids, middle cerebral artery, stroke. Hemorrhagic, again, hemorrhage, hemorrhage, hemorrhage. Read the words on your exam, guys. If it says hemorrhage, make sure you know it's bleeding out into the space. If it's an ischemic stroke, it's all internalized and stay inside. Also, really read the words on this test as well, because renal. Am I asking pre-renal, post-renal, or intrarenal? Don't read it so fast that you miss that key word. Which renal disease am I looking for? Is this pre, post, or intra? That will alter your answer very easily. Okay, so ischemic strokes, either thrombotic or embolic occlusion. Symptoms evolve over several minutes, may be preceded by brief episodes of reversible focal deficits known as those TIAs, transient ischemic attacks. Emboli from the heart, middle cerebral artery. And here it is. So let's follow this now. Let me change the color. Okay. We come out, follow this up, and it goes right there. Very easily. Middle cerebral is the biggest one because it's the fastest route, goes straight through. Big, wide arteries. Things follow the path of least resistance, and it goes right there. So the majority of atrial fibrillation patients will present with a left, or it could be right, middle cerebral artery infarct. This is the territories. So when I said we had everything mapped out, this is what I mean. The anterior cerebral artery is in yellow. So all of that brain tissue is fed by the anterior cerebral artery. Where is the motor cortex? Where is that located here? Anyone know? How do you tell the difference between the motor cortex and the somatosensory cortex? Central sulci, right? That's right here. So this is your motor side. This is your sensory side. This homunculus covers that area, and this covers this area. Keep this in mind when I show you the next picture, because then you'll see, oh, that makes sense. Why are we losing deficits here? Because it's a different artery. The middle cerebral artery, obviously, is all the red, and then the posterior cerebral artery is all the blue. Where is the visual cortex? Fed by what artery? Posterior cerebral artery. So if someone comes in complaining of, I have vision problems now, let's say I say that they're having a stroke, what artery do you think is probably causing that patient's blindness? Posterior cerebral artery. You see now, you know the location, you know what complaints they're having, what arteries are involved with those areas. So here's the homunculus. You break it up, and we know that when we start, the legs, feet, toes, and genitalia are on this side. This is the motor, or this is sensory on this side, and here's your motor on that side. Again, the lower extremities are in the top. As you get towards the head, the hands, the eyes, the mouth, you start dipping lower and lower and lower. Makes sense. What area is right there in green that well, that's sensory. Let's go to the motor side. Make it legit. Okay, we're on this side. Okay, this is the back of the brain. This is posterior, anterior. What region is right there with regards to language? Broca's area, right? And is that speech or comprehension? Speech. Look what's right in that area. The motor system that controls your mouth, tongue, and swallowing is all in that area. That's why it's Broca's area for the motor side. It's all mapped out. You know the map, you know what they're complaining of, you can figure it all out. So if they're now, let's change, I want to go to a highlighter. Okay, so let's go, this is the lower extremity, right? What vessel feeds that part of the brain? Let's go up here. I did it same color. You see? Lower extremity, anterior cerebral artery. Everyone see that? So if someone comes in complaining of right lower extremity weakness or strength, or my right leg is numb, I have paresthesias, numbness and tingling, what artery feeds the lower extremity in the brain? The anterior cerebral artery. So if they come in with lower extremity weakness, I know it's the anterior cerebral artery, because that's what feeds the motor and sensory part of the homunculus in those sensory issues. Let's go change the color to red. So now we go these areas. Middle cerebral artery. Middle cerebral artery. Upper extremity problems. Middle cerebral artery, because that's what feeds it. That's what feeds the part of the brain that controls that motor function. So that's why everything's mapped out. We can tell where things are. This is also why, if you ever hear people saying they go for like these open brain surgeries and they keep them awake, it's because first of all, the brain has no pain receptors. So you don't have any sensation of pain. They want to know what part of the brain they're messing around with, so they have you like play an instrument, or if you're an instrument musician, or do something that uses parts of your brain, because if you stop doing that, maybe they're in the wrong part of your brain and they didn't retract away the forceps or something. They touched the wrong part. It's just a way for them to know what's going on because they have the brain mapped out. We know that the upper body is middle cerebral, and so on and so forth. So another way of looking at it again, same thing we just went through. Another way of looking at it. Here's a good homunculus, right? Okay. Okay, so you can read that later. We'll keep going. Okay, so let's continue on with some more ischemic strokes. Okay. Small arteries at select locations where perfusion depends on those small vessels. Anything distal to the occlusion is going to become ischemic. Most result from degenerative changes caused by hypertension. So here's that hypertension again. We got to stop the hypertension. Most common vessels are involved. Just know basal ganglia and your brainstem and thalamus. So obviously we're going to start getting into some motor functions here and brainstem functions, vital processes. That's why remember your brainstem handles your heart rate, your breathing. You can live with a vascular stroke in the anterior cerebral circulation. If you start getting into the brainstem strokes, these are the people who present after having a stroke. They can't breathe on their own. Their heart rate is unsupported. Blood pressure plummets. They hit the brainstem. Very, very, very poor prognosis when that happens. And again, lacunar infarcts are always due to hypertension. Okay. And again, just more of your anatomy here. Remember, atherosclerosis also plays a role in development of cerebral artery occlusion. So all the things we learned about in cardio with regards to atherosclerosis are here as well. And it's always at those bifurcations where they're on the biggest shear stresses causing the biggest problems. So here are some pictures of some hemorrhages. These are CT. On CT, the bright white is blood. Okay, so you start seeing different strokes. This is not going to be on your test. Just showing you what they look like. Obviously, you know that they're hemorrhagic strokes. Epidural, this is why you have to know the layers of the meninges. Okay, dura, arachnoid, and pia. Subarachnoid hemorrhage is between what two layers? The arachnoid and the pia. An epidural hematoma, what layers? You guys better go back to your anatomy. What is a subdural hematoma? Yes. So an epidural is above the dura, between the dura and the scalp. Middle meningeal artery. Where's that artery? Middle meningeal. Right here on the side. This is the one when you get hit in the head very, very, very violently in the side, that middle meningeal can tear, causing a hemorrhagic stroke. You can die from that very easily. So you see people like in boxing, they die afterwards sometimes. Sometimes it's from that middle meningeal rupturing. This is a subdural hematoma. You can see the blood layer over there. Now, what this is pointing at right there in yellow, and I put it in green, this is called a mass shift, and I'm going to erase my green. If you look at that part, here and here should be a straight line through the ventricles. But look at the ventricles. They're being pushed to the right. Does everyone see that? Where the red arrow is. These are your ventricles. They're being pushed. When you see that, that's called a mass effect. Because of the bleeding over here, remember the skull is fixed, it can't expand. That blood is pushing the brain tissue in that direction. This will cause potentially seizures and other headaches, massive problems because of the mass effect there. This is a subarachnoid hemorrhage. So we're in the subarachnoid space. What also is in the subarachnoid space? CSF. So where do you think the bleeding is all going to go for this one? Into the ventricles. That's why you see all that blood in the ventricular system, because you're bleeding into it. One of the things we can do is do a lumbar puncture, because we're tapping directly into the CSF, and we're going to see blood in the CSF. Or it'll be like pink tinged blood. Very, very light, but it'll look different because there's bleeding going on. You have a subarachnoid hemorrhage. Okay, that's basically all I want you to know for these things. Don't go crazy into these things. We're going to do this all really in neuro. But just understand what they are. Okay, I will mention this though. This berry aneurysm. No, because this is another relation. So this is your vessel. We get an aneurysm. That thing is called the berry aneurysm. When that happens, those walls are very, very weak, and those things can rupture very easily, causing you to have a hemorrhagic stroke. There's an actress who had like 2 of these, and she's lucky to be alive. It happened when she was filming a great show that ended poorly. Anyone know who it is? Emilia Clarke, Daenerys from Game of Thrones. She had this aneurysm right after like that first season was filmed. She had an aneurysm. I think she had a second one that got treated. If we know that they're there, we can treat them. The problem is you don't know that you have them until you have the event, and then you go back. Unless you have what? Family history. Mother, father, sister, brother also had berry aneurysms. You should get checked out as well. And the last one. Almost done. Last thing is intraparenchymal hemorrhages. Again, weakened blood vessels. Eventually, get there. Weakened vessels. Anytime you have weak vessels, high pressure, they're going to burst. Hemorrhagic results. Intraparenchymal just means bleeding within the brain tissue. Just like intraparenchyma with the renal system. Intrarenal diseases are intraparenchymal. They're dealing with the tissue of the kidney themselves. Again, here's your hypertension. Always going to be there. Always with the hypertension. Other things that can cause vascular malformations where the arterial and the venous systems kind of have a communicating vessel in between. If people go for like dialysis, they get one artificially, but some people make them. And some brain tumors will do it as well. Cocaine, amphetamines will cause rapid blood pressure spikes, and that can cause strokes to happen as well. Cerebral amyloid. Amyloid, remember, these are infiltrative things. They're going to cause problems with the brain tissue. The last little bit is this thing on excitotoxicity. When you have a stroke, there's a tremendous amount of excitation going on in the brain. What is the main excitatory neurotransmitter? Glutamate. Glutamate kind of runs rampant with these strokes. The problem, if this is the area of infarction, that's dead brain tissue, it's not coming back. The areas right around it are under ischemic stress. Tons of glutamate going on. That's going to fry all of that tissue in the area because of this overexcitation. Adam, what do you verbalize it?
It's going to just keep spreading.
Exactly. The zone of ischemia is going to get bigger and bigger. So one of the drugs we give now are anti-glutamates. If they're having a stroke, we give them drugs that block glutamate to prevent that overexcitation, to prevent further ischemic spread. Remember, glutamate, major excitatory neurotransmitter, we want to block that. So again, the goal, this is what this last slide is saying. Block glutamate during a stressful stroke event, prevent further damage and ischemia from all that stroke. And again, this is all just talking about all that stuff. Don't worry about the rest of it. And that's the end of it. I don't have more detail on what would be done. Okay, we have a couple announcements from Dr. Leck Valentine.